go live on TikTok?
Yeah, go live on TikTok.
Hi, everybody. I am Dr. Rahi Victory, reproductive endocrinologist and infertility specialist. This is Fertility Fact or Fiction. We are starting up our show a little late tonight because of technical difficulties, and we have an amazing guest with us tonight, Dr. Ranjith Ramasani, who is a fertility urologist from the University of Miami, and he is joining us tonight to answer all of your urological questions. He will be joining us shortly. We are just getting him on the link, and super happy to have you guys here. Any urological questions that you have will be answered, and he should be joining us any minute. Is he available? He's there. So just to say this again, it's now the third time. Dr. Ramasani is a fertility urologist with an impressive academic career. He has co-authored more than 400 journal articles. He is the recipient of the Gold Cystoscope Award, as well as the American Society for Reproductive Medicine and Sexual Medicine Society's Young Investigator Award. He has an NIH grant to study erectile dysfunction, and he has even published in the Journal of the American Medical Association, which is one of the top-ranked journals in the world, so a very impressive career. I first met him at a recent conference in Chicago where he gave an absolutely brilliant talk, and I asked him if he would join us on the show tonight, and he was gracious enough to accept. My apologies for the technical glitches early on. Welcome to the show, Dr. Ramasani.
Thank you. Thank you very much for having me. Sorry about the glitch as well in the beginning, but very happy to be here.
Thank you. So we are very excited to have you on. I know at the conference you gave an absolutely brilliant talk, taking very complicated, difficult topics and breaking them down into really easy to understand ones. So would love to hear a little bit more about you, your interests in fertility urology. What made you even get into this field in the first place? And Tarek, maybe you can just turn up the volume for our TikTok viewers.
So I mean, as I went through urology residency, I was really interested in trying to help people with their quality of life. And there was one aspect of male fertility that I thought was very underserved. Not a lot of urologists like to go into male fertility. They like to do prostates and cancer and kidney stones and so on. And I thought this was a huge specialty that deserved a lot of need. And I liked helping couples get pregnant, having achieved their fertility dreams. And I thought, what a great way to do this on the urology side, where I know there was a lot of female fertility specialists that were specializing in REI, was sort of becoming a big field when I trained, but not a lot of male fertility specialists were there. And so that's what drove me to specialize in male fertility and now become a reproductive urologist, and absolutely love my career choice so far.
Fantastic. So what sort of research interests do you have from the reproductive side of things?
Got it. So I think we are now researching lots of environmental impacts on sperm. People, especially with the widespread use of cannabis, I know there are a few studies that have now showed that it doesn't affect the actual sperm count and the motility, and almost implying that that people can continue smoking if they're trying to have kids and achieve IVF or go through ART, but their male partners don't need to stop smoking or ingesting cannabis. But we're now actually interested to study the epigenetics. Maybe the quality of the sperm is not going to be good, because it has to have some impact on the quality of sperm, the sperm that's being used for an IVF cycle, and maybe its future impacts on offspring. And so we're actually doing a prospective study now looking at the impact of cannabis on sperm epigenetics and the quality of sperm. The other important thing is so relevant for us talking today. I think the headline, at least in the United States, over the last week has been about how hot it is in the US. Everywhere, Southwest, Eastern, Canadian wildfires affecting pollution and the quality of the air. I think global warming is going to have an impact on sperm. At some point, we've now actually looked at um, all different countries and fertility rates from 1980 to 2020, and have obviously seen global warming as a phenomenon that's happening worldwide. I don't think we need to disagree with that. But the hotter it gets, and the wider variations we see in temperature. So, for example, the hotter summers and the colder winters, I think we're going to see a lot more impacts on sperm. So, we're actively studying the impact of climate change, global warming on male reproduction and sperm parameters.
Wow. So just going back to marijuana, because I'm actually well known for being extremely anti-smoking, anti-alcohol, anti-drug use, including marijuana.
Yeah.
And in Canada, of course, where we are, marijuana is now legalized.
Right.
So tell us a little bit more about the marijuana impacts. I mean, I have read studies that show that there are significant impacts on sperm quality, including motility and morphology, less so in count. But then there are also studies on the DNA fragmentation. Can you touch on that a little bit?
Sure,
Tell us what
absolutely.
your read is. And
Absolutely. So I think the most popular study came out of Harvard, where they looked at people who smoke versus those that don't and compared their sperm counts and motility, and actually concluded quite opposite from what we've always thought, that it does not impact sperm motility. In fact, they made an argument where the sperm motility improves in smokers with marijuana. And we looked at serum testosterone levels in the enhanced cross-sectional database, and also, to our surprise, found that people who smoke the most have the highest testosterone levels compared to those that don't smoke or ingest marijuana. So
wow.
really, completely opposite to what I've been counseling patients, completely opposite to what you've been counseling patients. And
Yeah.
so I think we truly need a good prospective study to answer that question on what happens to sperm quality in men who consume marijuana. So I think that's where we are, and I think I think we need definitive studies to answer that, because we have studies that say it's safe, and we have studies that say that it impacts sperm quality. So, but you and me, we're both on the same page. I think it does affect sperm quality. How it does, how much it impacts, I think all of those are yet to be determined.
Are you enrolling in your prospective study?
So we're enrolling men who are attempting fertility who are current smokers of cannabis, and I ask them to stop. I'm like, no, if you're going to try fertility and I'm going to help you along with your fertility journey, we ask them to stop smoking or ingesting cannabis. And we're collecting sperm samples at 3 months and 6 months after they stop, and we're comparing the sperm epigenetics to how it was when they were smoking and compare it to how it is after they've stopped smoking.
Fascinating. Yeah. And how long have you been running that trial for? Is that just new, or have you already got some preliminary data?
We don't have it in preliminary. We've collected samples, about 6 patients so far. But after we get about 10, we're actually collaborating with Sarah Kimmins from the McGill University. And she's one of the leaders in sperm epigenetics. And we're trying to see if she can help us out with doing the bioinformatics and trying to figure out exactly what it is and what the mechanism underlying the use of smoking pot is on, and its impact on sperm quality.
Fascinating. What about alcohol and nicotine? Can you touch on the impact of those in regards to sperm quality, testosterone levels?
Absolutely. I think those are very clear. I think cigarette smoking, nicotine, vaping in any form, I think has been detrimental to sperm, both in terms of quality, motility. I don't think that nobody should come to us debating, doc, can I continue smoking? And I always tell patients that come see me, this is a balance. Here I am trying to fix your varicocele, trying to improve your serum testosterone levels, give you medications to try and improve your sperm count. And here you are smoking cigarettes and drinking alcohol every day, 6-pack beer once a day. And we're just fighting a battle. And there's only one person that's going to win in this. It's clearly the patient and all of those habits. And so I tell them, I'm like, if you want me to help you with your fertility journey, this is not an option. So the smoking cigarettes and nicotine and vaping, all of that has to stop. Alcohol in moderation is okay. A lot of people drink socially. I think all of that does not affect sperm. But people who drink regularly, who who think about alcohol when they wake up, when they actually have a serious problem of drinking it regularly, it will affect your testosterone levels and therefore definitely affect your sperm concentration and motility.
Yeah, and I've seen studies that show as high as an 83% decrease in normal morphology with moderate to heavy alcohol consumption,
Correct.
as well as the testosterone decrease, as you mentioned. So we always counsel quite, strongly for patients like you do to stop the smoking and the drinking. It is difficult, though. I find that as much as there's an incentive for patients to help themselves as they enter these journeys, and these journeys are often quite expensive, they're hard habits for a lot of people to break.
Right.
So,
Absolutely.
but
Talking of hard habits, I'd love to talk about obesity. I think I think that it's proven very well on the female side. I think on the male side, we have the first study that got published in Human Reproduction, I think last year, where they used liraglutide, similar to semaglutide, similar to these GLP agonists, where for the first time, obese men that actually lost weight on the medication, their sperm counts actually doubled. So far, we always tell patients, go lose weight, exercise, sleep better, everything is good for the sperm. We never had any objective data to say that sperm count will improve in men who actually undergo weight loss. And so with liraglutide, I think it's the medicine that they used in that study in Europe, where they showed that men can improve their sperm counts, can a 50% weight loss can improve their sperm counts by twice. And so I thought that was very interesting. And I think we, just like we talk about smoking, alcohol, and marijuana, we should talk about food and obesity. It often gets ignored. And I think especially with, I don't know how popular it is in Canada. In the United States, people are taking Ozempic like water. It's on every advertisement.
it's getting there for us too. It's not quite in the water supply, but I think it will be soon. Yeah, it's a lot of people using it.
Every major highway you see ads for Ozempic, and I think a lot of people are taking it. And I think we are going to start launching studies in men who have obesity and low sperm counts, oligospermia with obesity, where we offer almost no medical therapy because that Clomid has an adverse effect of gaining weight. And so we can't give medications like Clomid to men who already are overweight, and we can't expect them to lose weight and improve their sperm count. So I think in that patient population who are obese, who have pre-diabetes, I think thinking about using GLP agonists and things like semaglutide and Ozempic to try and improve their sperm counts, to try and get them from IVF to IUI range, to try and get them from azoospermia to oligospermia. I think all of that will become part of routine male fertility reproductive urology practice in the next few years.
Amazing. So have you seen in your own practice, like have you started using Ozempic for your obese patients?
We actually have. I mean, we're now at least consulting with an endocrinologist and asking them to do it. But we talked about research and how active we are with male fertility research. That's one study that we're now starting a single center open label trial to include men who have BMI greater than 30 and have low sperm counts, to try to see if we can treat them with semaglutide and try to see what their sperm counts happen in 3 months and 6 months.
Yeah, and I certainly haven't seen any data indicating that there is a negative impact of Ozempic on sperm parameters. Have you seen anything that says we shouldn't be doing it?
No, I have not. I think I've only seen data on people who lose weight and who don't on taking the medication. And I think the people who don't lose weight, not surprising, their sperm counts will improve.
Sure.
So no, there's no negative data so far.
That's fascinating. Yeah, I do think it's a huge part of what we experience, and certainly on top of the bad habits we mentioned earlier, weight is a big dilemma North America wide. I know it's a huge epidemic in the States, and in Canada we're not quite as significant as saying it's an epidemic, but it is a problem here as well. So we definitely have to deal with this, and I do tell a lot of my patients your diet is critical. We make sure that they're trying to balance their diet, eat much more healthy, exercise regularly, get their weight down. That kind of brings me maybe to the next best topic, which is obviously we have a lot of guys out there with low sperm counts, and they're compromised for various reasons. What is your sort of general approach to first evaluation and then treatment for those guys? So, if a guy shows up and his sperm is showing low count, maybe low motility, low progression, low morphology, what's sort of your approach to this, aside from, hey, get rid of your bad habits and lose weight? What other sort of testing do you recommend, and then what do you start with as far as treatment is concerned?
Absolutely. So usually we start off with a good history, because I think you know this very well. The three most important factors of fertility are female age, female age, female age. So this is no longer just a man's problem. It's a couple's problem. Very different from most other specialties in medicine where we treat the patient and the patient alone. But in fertility, we always have to take the female into account. If the female is older or has female factor fertility issues and needs to undergo assisted reproduction for any reason, then usually our counseling is very different in terms of, all right, let's do X, Y, and Z to try and improve your sperm counts. I think it's best that we get the female partner to a female fertility specialist. I think because of all of these reasons, I think doing ART is probably a very good idea for them. If the female is young and don't have any female fertility factors, and we do have time on the male side to try and optimize the sperm count, one of the few things is we do a simple physical exam. If there are correctable factors like large varicocele that can be fixed to try and improve the sperm count, there could be epididymal obstruction that can be fixed with surgery to try and improve their sperm counts. And ejaculatory duct obstruction, we saw a guy today with azoospermia and absolutely makes no ejaculate from the seminal vesicle because of a low volume and low pH. So we could offer ejaculatory duct obstruction relief with Tourette operation to try and improve his sperm count. I think all of those things we can do on the male side if we have time on the female side. So if the women are younger, they're healthy, and they can conceive naturally, then obviously on the male side, physical examination, simple things like checking hormone levels. If your testosterone is low, to try and see how we can optimize that testosterone level endogenously, not by giving you testosterone, but endogenously trying to push your own testes to make more testosterone in hopes that the sperm counts will improve, I think are all good strategies that we do on the male side, as long as the female partner is young and can conceive naturally and has time for the male sperm counts to improve.
So in terms of improving testosterone levels in men with low T, because I know a lot of them are coming to us from family docs, and the family docs are basically saying, hey, go on testosterone, and then obviously they stop producing sperm in many cases. So what is the optimized approach from the male urological perspective to increase testosterone while facilitating sperm production?
Absolutely. So there are medications like clomiphene citrate, HCG, anastrozole, and letrozole that are used actually on the female side to try and boost egg counts, but we use it off-label in men to try and see if we can boost sperm counts and endogenous testosterone levels. Exogenous testosterone therapy, mostly in the form of injections and steroids, will absolutely suppress sperm counts. I think there's no doubt about that. Unfortunately, doctors are always used to seeing, oh my gosh, your testosterone level's low, let me give you testosterone to try and increase it. And they often don't even ask the question, if the guy is trying for fertility, does he have future reproductive needs? Are you going to have more than one child? Oh, you have one child. They make the assumption that they're going to be done with their family planning and they give them testosterone therapy. So a lot of misconceptions thinking that if I increase your testosterone level by giving you testosterone, your sperm counts will improve. Quite the opposite, quite the contrary to what you mentioned. But I think if you do see a reproductive urologist trying to think about using medications like clomiphene citrate, HCG, anastrozole, letrozole are all good options to try and improve your own testosterone production. Taking testosterone exogenously can bring your sperm counts, like you said, to like almost zero within 2 to 3 months, and then we can reboost the system with medications like Clomid and HCG. It'll take up to 3 to 6 months for the sperm counts to come back, at least in majority of men. But certainly those are all treatment options for men who have no sperm and have been using testosterone and or other steroids.
At the talk you gave, again, brilliant talk, thank you. You mentioned there were certain situations where HCG might be the more appropriate choice, others where Clomid might be the appropriate choice, and some where obviously you use both together. Is there a particular time where you think, again, just for our viewers, where one is better than the other or both are important together?
Absolutely. So I think in majority of men, clomiphene citrate is a very good treatment option to start. And usually I love to start in men half the dose that we give in females. So it's about 25 milligram, which is half a tablet. And because clomiphene citrate has such a long half-life, even using it every other day without giving a drug holiday, because men don't have periods. So no drug holiday, and to just continue it for 3 months, I think is a very good option. In men who have hypogonadotropic hypogonadism, which is a very rare genetic condition where the hypothalamus in the brain does not connect with the pituitary gland and the neurons are absent. In those patients, clomiphene citrate will not work. And those conditions, I think using HCG alone is a very good treatment option. In men who come off of steroids, who their family medicine doctor has given it to them, their friend in the gym has given them steroids, their trainer gave it to them, and now they've been using testosterone therapy for however many years. Sometimes they started as a teenager and they've been using it, and they don't even tell you that they're taking this as a medication because they think it's just vitamin T. And they come and they have fertility issues and they have no sperm in the ejaculate. Those patients, I think, using the combination, both clomiphene, HCG, throw everything at them to try and improve their sperm counts, I think it's all a good treatment option.
Ejaculate. When do you feel in the fertility sort of process, is it better to go for the ejaculated sperm versus the times where we have to go for extraction, whether it's a PISA or a TESI or a micro-TESI? So when do you recommend to patients, hey, you haven't succeeded, now it's time to consider the extraction? And I've been looking at the articles recently suggesting that for patients that have had IVF failures, poor fertilization, even with ICSI, from ejaculated sperm or poor embryo development, there are some studies that are suggesting that the extracted sperm may do better, and at the same time there are others that are saying it makes no difference. What's your take on that?
That's a very good point. So I think now you're discussing about particular sperm and what happens when you get sperm from the testes. So sperm that are obtained from the testes don't have as much capability of fertilization. So if you have 10 eggs and if you have 10 sperm from the ejaculate, there's about an 80 to 90% chance that the 10 eggs would fertilize. Whereas if you have a low fertilization rate from the cycle, then using testicular sperm is not a good idea, because testicular sperm fertilization rate success is about 40 to 50%. Okay. Majority of the testicular sperm can be non-motile, and trying to use that sperm for the next IVF cycle, just remember that the fertilization success will be low. But when the embryo progression is poor, meaning we had 10 eggs, 8 of them fertilized, but we ended up with only 1 embryo at day 5, then using testicular sperm and ejaculated sperm in combination is a good idea. Or you can just use all testicular sperm if you find motile testicular sperm on the day of egg retrieval. So in some rare patients, I think we've seen this as well, they don't have any ejaculated sperm, or all of the sperm in the ejaculate are dead. In those cases, we don't have an option but to use only testicular sperm. Whereas in patients that have sperm and have gone through an IVF cycle, if they have low fertilization, going to testicular sperm is not a good idea. If they have poor embryo progression, then going to testicular sperm, and I usually use half and half, 50% testicular sperm, 50% ejaculated sperm, just so the couple has good options for their next IVF cycle, I think is a good idea.
Interesting. And that's true, that 40-50% fertilization rate is true even if you're using ICSI with the extracted sperm?
That's correct. Yes, absolutely. In fact, I don't think you could do conventional IVF with testicular sperm. You have to do ICSI with them.
You have to do ICSI, yeah. Yeah, interesting. So, so basically, you're looking more at the embryo progression and the development, and in those instances, it may be reasonable to do the extraction procedures. And do you think there's a significant difference between a epididymal extraction like a PISA or a TESI, or is it pretty much the same at that point?
I think at that, once you get down to the testes, I think it's pretty similar. It also depends on where you find the sperm. So in patients who are not obstructed, who've not had a vasectomy, getting sperm from the epididymis to the PISA will be a challenge. Those patients, you just have to go to the testis because if you're not obstructed, you won't get sperm from the epididymis at all.
Right.
Whereas in patients who are obstructed, who've had a vasectomy before, who have some sort of chlamydia, gonorrhea, and they have enlarged epididymides, you can get sperm from the PISA, and that's totally fine.
Okay. Um, that's gonna another great segue, and I won't keep you too long, but
No problem.
you're a wealth of knowledge, so we love having you here. We do get a lot of patients that come to us where they're with a new partner, and the partner previously had a vasectomy. Now, I know that vasectomy reversal success has some association with the duration from the time of the vasectomy. The number that we were clinically taught was 7 years, and that beyond that, there's so much anti-sperm antibody production that the function of the sperm can be compromised following reversal. Do you have updated information on that? What are you advising your patients? Are you telling them to skip that and go straight to an extraction and IVF, or are you still offering it to them as an option to get a reversal?
So I usually come back to with female age and female factor fertility. So if the new partner that the guy has married is 41, she has diminished ovarian reserve, she has PCOS. I don't care if his vasectomy was 2 years ago. I still recommend them to undergo a sperm retrieval because even if you succeed with vas reversal, she on her side is going to be difficult to conceive naturally. And
Right.
so I usually use female age and female factor as the decision point. If a guy has undergone a vasectomy 15 years ago and the female is 25 and she is as healthy as can ever be, she has regular periods, she's been evaluated by her gynecologist, and she can conceive, even with a little bit of sperm after the vasectomy reversal, despite having anti-sperm antibodies, maybe she could get pregnant. So really, I come back to using female age and female factor fertility as a decision point in that. I've done vasectomy reversals 27 years out, and the couples have conceived. But again, there, I am not telling you that the wife was 28 over there and she was as healthy as possible, and therefore they
Right.
conceived. So I think it really is dependent upon female age and female factor fertility to guide decisions on vasectomy. I use vasectomy, time since vasectomy, as a landmark. I think 7 years, and then the updated data is now 9 years to have a 50% chance of successful pregnancy if it's less than 9 years. But I've sort of moved away from using that because I feel like even if I do a very good job and the female is older and has a poor AMH and endometriosis and having fertility issues, me and the guy will be celebrating saying there's so much sperm back in the ejaculate, but they're not walking home with a baby. And I feel bad that they should have really, having the walking home with the baby should be our first priority and not a
Right.
successful vas reversal. And
Right.
so we sort of moved the discussion away from time since vasectomy and more towards female age, female factor issues, and then using that to guide the decision on whether the couple should proceed with vas reversal or sperm retrieval.
Yeah, and that's a great approach. I mean, I would agree with you 100%. Um, well, thank you so very much for all the incredible information you've provided. Very, very happy to have you on the show. I don't know if Tarek, there were any questions for Dr. Ramasamy. Maybe we can turn to some questions if that's okay with you.
Let me check on Instagram.
We got one comment on TikTok, because I'm on TikTok as well, where someone said by the year 2050, 50% of women will have trouble having a baby by the time that they want to get pregnant. Whether that's male factor or female factor, they didn't elucidate, but that's I haven't seen that statistic certainly, but I have seen estimates that by 2035 they're expecting that as high as 20% of the population will be infertile, and that right now it's about 15%. Are you seeing that in the male factor? Do you think
Absolutely. Absolutely.
historically male factor is increasing?
Absolutely. I mean, I do not want to get into the declining sperm count debate today. I don't think that's for me and you and the viewers to have.
Yeah.
But we have noticed male reproductive aging, which I have never noticed before. And when I mean male reproductive on the female side, we're all very aware.
Yeah.
Women are born with a whole set of eggs, and with age, the number of eggs continue to
Sure.
decline, the quality of eggs continues to decline. And on the male side, actors like Al Pacino make it seem like you can father a baby at 81. And somehow men always think that their sperm counts will almost never go down at all. But the phenomenon that we've been noticing is guys who came to us before the pandemic with a lot of sperm and then have just waited for many reasons to like conceive and are coming back to us. We're now seeing a lot lower sperm counts than they have. And we're seeing the concept of male reproductive aging. 2 years ago, they had some sperm in ejaculate, and now they've gone to having zero sperm in ejaculate. And so I think it's a phenomenon. Is it the environment? Is it the genetics? Is it because we're following these guys a lot closely and they have access to a male reproductive urologist that we're actually getting their sperm counts regularly that we're noticing this phenomenon? I'm not so sure. But I think male reproductive aging is definitely a phenomenon, and I don't think that should be debated. And it happens in a small subset of patients. Maybe it is in those patients where fertility becomes an issue. But absolutely true. I think there's a question on supplements. We could have
Are
another
you
podcast
sure?
on supplements, but
Yeah. What about supplements? Which ones do you recommend for men to use?
absolutely. So I used the one that was studied in the NIH study and published in Fertility and Sterility called Conception XR. I have zero conflicts with them. I don't receive any honoraria or grants from them, but because it was studied in the NIH study, at least for the safety part, I use it. But I use it truly in men who have idiopathic low sperm counts. I don't think supplements can actually improve concentration, but I think they definitely can improve sperm motility and morphology and their quality. And so, because there are not too many negative side effects associated with it, I do recommend taking those supplements, especially with zinc, CoQ10, and carnitine. I think those are probably the most important. Selenium, if truly I want the motility to improve and the concentration is very high, then I do recommend adding that on. But really, those are probably the most important supplements to take in men who have low sperm motility without any underlying cause. No large varicocele, no chlamydia, no sauna issues, no heat issues. I think in those patients, supplements will actually make a difference. Not in everybody, which is what the study did.
Anything else there, T?
And then
There's a lot of sperm
there is
questions.
a question on division of sperm. If it stops at day 3, could it be an issue with the sperm? If so, what could be the issue? That's a very good point. So I always tell fertilization, if you look at the size of the egg, is about 50 times the size of the sperm. So the first day of life, when after ICSI is done, really is dependent on the egg. If the egg cannot drive the sperm to day 1 with the fertilization, then and it's likely an egg factor, because all the sperm does, it provides the DNA and the nucleus. All of the other organelles that the cell needs to live and function comes from the egg. Once the fertilization happens and then it stops progressing, there could be sperm DNA issues. And one of the things that we are studying, and I think we never talked about it, is using sperm DNA fragmentation. What does that mean? So sperm DNA can be broken at one place, multiple places. DNA has 2 strands. It can be broken in both strands. And that could be a factor for why the embryo are not progressing all the way. And I think we spoke about this a little bit. Trying to use testicular sperm as a bypass for sperm DNA fragmentation, I think, is a very good idea in failure of embryo progression, not in fertilization failure. And the other simple way we're now trying to treat sperm DNA fragmentation is to decrease the abstinence interval. Normally, sperm analyses, men are asked to abstain 2 days to 7 days to 5 days and so on. We're now asking men for sperm DNA fragmentation and for quality of sperm to abstain like 12 hours. So ultra short abstinence intervals to try and get better quality sperm. Because the longer the sperm gets stored in the body, the higher the chance that it can be exposed to all of these toxins and the chemicals and the exposures and the smoke that we talked about, and can get fragmented of the DNA fragmented in the sperm. The faster it comes out, so the second ejaculate that's obtained usually has much better sperm DNA fragmentation. And if you do have issues with DNA fragmentation, speak with your doctor to just repeat the test with an ultra short abstinence interval and see if that improves it, and that should be the simple fix.
Yeah, we've actually, for quite some time now, there was a study I read, I think it's probably 18 months ago, 2 years ago, which demonstrated that a 3-hour interval resulted in an 80% decrease in sperm DNA fragmentation. So what we're doing for those cases where they are high is we're having them ejaculate once early in the morning, and then we're having them come in and give us a second sample 3 hours later, and we're typically using the second sample for the ICSI and getting much better embryo development from that. So there definitely is something to say about the frequency of ejaculation. And that touches on probably the most frequently asked question, which I'll ask myself because I'm sure many people have this on their mind. What is the right frequency of ejaculation just to optimize your sperm performance?
Every other day.
Yeah.
I think that studies have shown every day. And couples always ask me, they're like, how often should we have sex when we're trying?
Yeah.
One of the things that happens is everybody's using apps now, ovulation calculators. Every female partner is calling their husband and saying, "Come home today. We need to have sex at 7 p.m. If you have late, if you come home at 8 p.m., I'm not going to have a baby this month. So come home at 7 p.m." And so that increases tremendous amount of stress on both the male and the female partner. And so usually the first thing that I ask couples to do is to throw out the ovulation calculator, because clearly they've been trying it for the last 6 months to 12 months before they came to see us. So I'm like, throw that out and at least have sex every other day. So after the periods finish every other day, around the same time, not 2 a.m., 3 p.m., 1 a.m., and you could miss that window. So I usually tell them to do it every other day around the same time, at least 6 times, in women who have regular periods and who have ovulatory cycles. They have irregular periods, that doesn't apply, but at least every other day is a good time and a good frequency to have intercourse for couples that are trying to conceive naturally.
Fantastic. More questions?
There's a lot.
Go for it.
There's a lot of questions. Okay, the most recent question that just came in, just to give them something new, and then we'll go something back and forth here. For Dr. R, can a man at 52 still produce good sperm with lifestyle change, or will the sperm be bad because of age?
That's a very good question on advanced maternal age. We always talk about advanced maternal age, and oh my gosh, after 42, the egg quality goes down. After 37, it starts declining. In men, you could be Al Pacino and have kids at 81, and so don't worry about your sperm. I always describe, sperm as a factory. So when you go through puberty in men, the factory starts making the sperm. But as we get older, some of the parts in the factory get older and rusty. So you still make the product, you still make cars, but these cars come out deficient. And so at 52, your factory can still be functioning and make sperm, but unfortunately the quality of the sperm may not be as good. And so the answer is yes. I think you'll still make sperm, but the quality can be impacted. And so a 52-year-old guy that's leading a healthy lifestyle, that's eating well, does not have obesity, doesn't smoke, doesn't use marijuana, I think your sperm will be the best it possibly can. But a 52-year-old guy who has diabetes, who has obesity, that's smoking, will have much worse quality sperm than a guy that's healthy. So I think it's important that age, yes, can do it, but if you add all of these lifestyle factors on it, you'll have much worse quality than you possibly can.
Dr. R, if the division of sperm egg stops after day 3 or slows, could this be an issue with sperm? If so, what could be some of the issues?
Yeah, I think this we discussed. This is the DNA fragmentation. So if the embryo doesn't get all the way to day 5 and you have a lot of eggs that fertilized on day 1 but have very few embryos at the end of day 5, it could be an egg issue. Don't blame the sperm. But at that point, it could be a sperm issue as well, which is when I intervene and check the sperm DNA fragmentation. And we discuss some of the strategies to bypass sperm DNA fragmentation to either decrease the abstinence interval, which you're already doing, Dr. Victory, with 3-hour abstinence, 4-hour abstinence intervals. And also, if that's still bad, then to try and use testicular sperm for the next cycle is a good strategy to try and overcome that.
Just trying to find one specific for you. Okay. If quitting cannabis for over 3 months hasn't improved sperm sufficiently, what now?
So we don't know the answer to that question. We have to wait for my study to come out. So I am very optimistic that we're going to find significant quality of changes in epigenetics and after quitting cannabis for 3 months. So remains to be seen. We keep talking about sperm and egg and so on, but some of these. So let me define to the audience what epigenetics means. So we're all born with a set of mutations, and we grow up with this. Epigenetics are where things like smoking, exposures, chemicals, pesticides, pot can all change the way that our DNA actually functions. And some of these can be transmitted. And we never talk about this because we're not going to be around for the next generation to grow up and have these things. But all of these exposures that we're doing can potentially be transmissible to the offspring. And so, in couples that are actively conceiving and trying to make the next generation, think about what we're transmitting. Yes, we're getting offspring, but how are they going to grow up? What are genes are they going to have? Are they going to have issues in their genetic pattern based on what we consume, what we eat, what fast foods we consume, what pollutants we're exposed to, what cannabis we're exposed to, and the transmissibility? I think is something that we never discuss, and it's going to be too late by the time we realize all of the things that we've done in this world.
Um, is it true that a varicocele repair doesn't always improve sperm count?
Yeah, it's true. So 70% of the time, the sperm counts will improve. 30% of the time, it is not. And I think that's why it's important to have a discussion with the female fertility specialist and the reproductive urologist on whether it is right for the couple or not. Going back to the same question of if you have an older female who has to undergo IVF because of any underlying female factor fertility issues, trying to do a varicocele repair and trying to improve sperm counts and wait the 3 to 6 months, not such a great idea. But if the female partner is young and she can wait 3 to 6 months to see what the sperm counts improve with varicocele repair are, I think it's a very good treatment option. So I think truly it should be a couples discussion and not just a let me fix my varicocele to improve my sperm count discussion.
You know, the one thing I've seen with varicocele repairs, and I'd love to hear your thoughts, is that typically there's a bit of a blip where we see initially after the 3 or 4 months there is an improvement, and then over time it often will drift back down. Not quite as bad as it was before, but not as robust as it was initially either. Is there any, like, is that just my gestalt, or is that something that actually is out there scientifically as well?
I've never seen it dip. The only time I've seen it dip is when there is a recurrence. So varicoceles can come back in 5 to 10% of the time. And anytime I see a dip, the first thing I go back and is re-examine or repeat a scrotal ultrasound to try to see if there is a recurrence. And usually when there is a recurrence, that's when you know it went back down. In fact, those recurrences I'm more optimistic to go back and fix because I know if I do fix it, that I can improve the sperm count to back where the rise was. And so if they never had an increase and if they have a recurrence, I don't fix it. But if they have an increase and they have a recurrence, then I usually push. As long as, like I said, we go back to the female factor side. As long as we have time and we can wait on the female side.
Okay.
Why testicular sperm is better for embryo progression? Should a couple consider this if their embryos arrest on day 4 or 5?
Yeah, so I think we discussed about this. I think sperm DNA fragmentation is a major problem. Ejaculated sperm usually has worse sperm DNA fragmentation than testicular sperm. Testicular sperm are a bit more immature, but they also have the benefit of not being exposed to exposures like smoking, alcohol, radiation, heat, sauna, cell phone, pollutants, pesticides. And so they have typically lower sperm DNA fragmentation. And so when there is poor embryo progression after good fertilization, there is a pretty high chance that it's likely because of underlying sperm DNA fragmentation. And so therefore using testicular sperm, which typically has a lower sperm DNA fragmentation, is a much better option to use than ejaculated sperm that typically has higher sperm DNA fragmentation.
Right.
Does COVID have long-term effects on sperm quality?
That's a very good question. So we actually at the University of Miami were one of the first few centers to identify COVID in the testis in men who had recovered from their original infection. And we actually showed that the virus can be present even 6 to 9 months after the original infection. So far, long COVID studies have showed that there can be decreases in sperm motility and sperm DNA fragmentation up to 7 to 9 months after the initial infection. But beyond that, we don't have studies and people have stopped studying COVID because it's no longer sexy. But I'm fairly certain that if it does linger in the testis, it can still have long-lasting effects on sperm quality. It's not the
And
flu. People always
and
think
what
it's
about
just
the
the flu.
vaccine?
So what about the vaccine? I thank you for giving me a shout out to the JAMA paper that we published. We
Yeah.
actually showed that the vaccine is not the virus. It does not enter the testis, and the vaccine does not have any impacts on sperm count, sperm motility, or sperm DNA fragmentation. The actual virus does.
Yeah, I think that's so important to tell people because even still, in fact, possibly even more than previously, there is a whole wealth of people coming out with their, Facebook degree of medicine saying that, the vaccine caused their sperm counts to do this or cause their fertility to do that, and trying to dispel these myths is like a full-time job, just trying to explain to people that's not even biologically possible, but
Right.
no one wants to listen. So it's great to hear that this was studied, published in a world-class journal like JAMA, where it demonstrated quite clearly that that is not the case.
Absolutely. I mean, there's people selling vaccine-free sperm on the internet. So, yeah. So I think it's. I think it's.
You know, we actually get that all the time. I do a lot of third party work with
Yeah.
people that need egg donors or surrogates, and we have an enormous number of people saying, I want an unvaccinated egg donor or I want an unvaccinated surrogate because they think it's going to have some sort of negative impact on their child. Getting them to understand that that's just not possible, even biologically. I'd have a better chance of getting a raindrop to put a hole through a rock. It's not going to happen.
Right. No, absolutely. No, you know.
Last question, because we've taken up an entire hour of this poor man's time.
I got a good comment.
All right.
It must be nice to be a man. Only prescription is to ejaculate every 48 hours.
Well, you have to ejaculate into the right place. I swear to God, as much as we teach sexual abstinence and STDs in high school and in middle school, I feel like we also need to teach reproduction. All that we teach is fear and sexual abstinence and chlamydia, gonorrhea, and STDs. We never teach what the right thing to do is. And you just say the word ejaculate. I've had couples come to me trying for conception with anal sex for the last 3 to 6 months. And if you don't ask the right questions, you don't get the right answers. And it's not just to ejaculate, you make sure you find the correct hole to ejaculate into if you're actually trying to conceive. And so I think as much as we try to teach sex education and abstinence and safe sex in schools, we also need to teach what the right thing to do is before we teach the wrong thing to do is, because sometimes we forget what the right thing to do is, and people don't ever learn what the right thing to do is to actually have kids.
Excellent comment, and I appreciate you adding that in. I think we're going to wind it down. It's almost 9 o'clock. So, again, I cannot thank you enough. You are a wealth of information, and I love the way you convey your message because it's easy to understand, it's informative, and I think you've done a tremendous job of educating our audience. If some of the patients out there, because we do have a fairly large audience in the US and Canada, want to get in touch with you, what is the best way for them to do that?
The easiest way is to follow me on Instagram. I think everybody are on social media. It's my last name, Ramasamy, Ramasamy, MD. It has my office info. It has my email address. And so people that want to reach out to me that way, you can do it. For those of you that don't like social media or not on social media and want to email me, it's my last name, Ramasamy, Ramasamy @miami.edu.
Amazing. Thank you so much. I will likely call on you again in 6 months or so to get you back on, and maybe you can review some of the results of your studies if there are updates at that point. Can't thank you enough. Wonderful to have you on the show. Huge thanks and lots of love and hearts and thumbs up for Dr. Ranjith Ramasamy from the University of Miami. Thank you, sir. Have a great evening.
Thank you very much. Bye-bye.
Take care. Bye now. Okay, folks, we've done an entire hour with the amazing Dr. Ramasamy. So I'm sure there's a ton of other questions, but I think we're going to wind this show down. Any standouts you want me to do before we let everyone go? One major question.
A major question. They all enjoyed the show.
Carly says, people don't understand how things work scientifically and just talk out of their... and then I blank out the rest for her.
Yeah,
Thank
sure.
you, Carly. Yes, it is very frustrating. That is true. Yeah, absolutely.
No standout question, just, generally questions.
You want to screenshot them and I'll try and
Yeah,
do it. I'm on
sure.
call on Saturday. I will make lots of little videos and answer your questions on Saturday, guys. Tarek will screenshot them for you. It is 9 o'clock. The two of us are starving. And you guys had some wonderful questions for Dr. Ramasani. So have a good night. Thank you for joining us. Sorry for the technical glitches. This multi-platform thing is often quite difficult to navigate, but we are so happy to have the opportunity to share this information with you all. Is it next week we have the fertility coach, or is it?
I believe it's the following. I'll double check for you. Yeah, the 25th.
It's next week.
Yeah.
So Elizabeth King is going to be with us, very popular fertility coach. So we are going to chat with Miss King about her experiences and insights. And I think we're going to have Nathan Treff on, not the following week because I'm taking a holiday, but the week after that. So we will be back again next week with Elizabeth King. Have a great night, guys. We'll look forward to answering all your questions. And we'll see you next week on Fertility Factor Fiction.